most important issues facing our industry today, and that's the issue of surprise medical billing and freestanding ERs and what Texas is really doing to protect consumers. Fortunately, today we have Dr. Dan McCoy, president of Blue Cross Blue Shield, here with us to moderate this important discussion. Dr. McCoy is a physician entrepreneur and communicator with a passion for improving the way we deliver health care for Texans. Dr. McCoy grew up on a cattle ranch in Central Texas, and from a young age he knew he wanted to be a physician. After 20 years of experience as a practicing physician, he was named president of Blue Cross Blue Shield of Texas, following his service there as a divisional senior vice president and chief medical officer. Thank you, Dr. McCoy, for joining us today. And continuing on our panel, we have Chairman Frullo. We're so pleased to have you here. He's an esteemed member of the House of Representatives from Lubbock, Texas. He was first elected to serve in the 84th House District in 2010, and today he is the chairman of the Committee on House Insurance. He is a key leader in the House, respected on both sides of the aisle, and someone that our members look to for guidance on priority issues facing our industry in the entire state of Texas. We also have, and are pleased to introduce, the Texas Commissioner of Insurance, David Mattox. Commissioner Mattox was appointed January 2015 and oversees the Texas Department of Insurance, which regulates the insurance industry and provides information assistance to insurance consumers. Commissioner Mattox also serves in a variety of capacities with the National Association of Insurance Commissioners, including chair of the Financial Regulation Standards and Accreditation Committee, Vice Chair of the Finance Conditions Committee, and Secretary Treasurer of the Association Western Zone. He previously served as Deputy Attorney General for then Texas Attorney General Greg Abbott as a member of the State Bar of Texas. We also have Kelly Hancock. Chairman Hancock serves Senate District 9, which includes portions of Tarrant and Dallas County, and he is chairman of the Senate Business Commerce Committee, which hears insurance issues. He served 3 terms in the Texas House before being elected to Senate, and throughout his service in the House and Senate, he's led on important issues to our industry, particularly on the issue of surprise billing. He championed the mediation solution for consumers in 2009, which created mediation in the state of Texas for the first time to protect consumers from balance billing, and expanded the solution to consumers in 2015. We're pleased to have Chairman Hancock and welcome here today. And last, we have Stacey Pogue, who is a senior policy analyst for the Center for Public Policy Priorities. She's been with the center since 2008 and has previously worked in the Texas Department of Insurance and the Health and Human Services Commission. She was twice elected to serve as the consumer representative to the National Association of Insurance Commissioners as one of the state's leading consumer advocacy voices on private health insurance and consumer protections. Legislators, the media, and stakeholders turn to Stacey for her insights on these issues, particularly surprise medical billing and how it impacts consumers. So with that, I'd like to thank our panel for joining us today and turn it over to Dr. McCoy, who will moderate this afternoon. Thank you.
Thank you very much. I cannot tell you how excited I am to be here today to have this conversation. I'm gathered on the stage with 4 of probably what I would tell you the most experts when it comes to surprise billing, balance billing, whatever you want to call it. And the intro said Texas, but I would argue in the country, because this issue has certainly been studied in Texas and talked about in Texas for almost a decade. This issue, you can always tell when an issue becomes important to a consumer, and that's because your neighbors start talking about it, right? So you start to run into people at the grocery store and they start asking you, what about this surprise bill? And it's no longer the fact that a small added charge was put on that EOB, but actually charges in the tens of thousands or even hundreds of thousands of dollars that are surprising patients, and as a physician, surprising my patients before I came to Blue Cross. So excited to have this conversation today, and hopefully we'll have a little bit of time at the end of the panel to be able to engage some questions from the audience as well. In addition to seeing the amount of the bill that's being questioned, there's a lot of discussion about, where does the amount come from? How is it allowed to occur? There's a lot of blame going on. And when you have a multi-stakeholder issue like surprise billing and balance billing, and particularly as it relates to freestanding emergency rooms, which we'll discuss those as well, there's a lot of blame going around. The physicians and really the providers, they blame the insurance companies. They say it's the fault of really not having an adequate network, or it's bad benefit design. The insurers will often say that certain physicians and providers have business models that are really meant to make money and not really provide health care as it should be. And their business models are really guided to a business model that encourages them to be out of network. Employers and the Affordable Care Act will often say that healthcare costs require insurers to offer benefit designs and really kind of encourage this idea of narrow networks. Consumers say it is too difficult to navigate all the requirements, and it's not their fault when they receive care from an out-of-network physician at an in-network facility, especially in emergencies. So what do we need to do? But before we get started, let's kick this off, as many of your panels have done so far, with this kind of question. In light of the presidential election that happened last week, what do you think the Texas legislation may wish to revisit or redo or relook at, given the election that occurred last week? Any thoughts? Senator Hancock?
Well, I think the majority of the changes we're not going to know until we know. And so there was a lot of discussion in the campaign trail. We're a little different than the state of Texas, meeting every other year. We're going to be a little bit in a position that as session moves on in the 140 days that we're going to be there, in a position of really kind of watching and waiting and seeing what happens. We were talking earlier that I think the majority of our work when it comes to healthcare and the changes that we see at the federal level will come during our interim. And so by the interim times, 7, 8 months from now, we'll have a pretty good feel of the direction that the federal government's going to go, the changes they're going to make, and begin there. Then at that point, the process of evaluating, discussing, working with them to seeing what we need to put in place. Because when the Affordable Care came to across the nation, it forced many states, such as Texas, to change the model that we'd been using before. And I don't know that we loved our model before. We liked it better than the Affordable Care Act, but it caused us to change our model. So rather than just reverting back to what we had in the past, I think it'll give us a chance during that interim before we come back in the next session to really evaluate and look at what we need to put in place, what we need to get rid of. And I think one of the things we're going to have to do is align ourselves more equally from state to state if you go with what our president-elect was saying as far as cross-border transaction and creating more of a free market within that arena. But I don't see a lot this session. I see a great deal. I see it being one of the larger issues that we walk into next session.
Chair Frullo?
Thank you, and I agree a lot with what Senator Hancock said. Looking forward, we've already seen what was the campaign used to get into office and all the activity and rhetoric associated with that. And no sooner did the election occur that we start seeing some information, and I know that you've had several sessions here to talk about that and what all is happening as far as what the plan going forward is. We kind of went from completely scrapping Obamacare to now where we may, or ACA, where we may be keeping certain parts of that. And as Senator Hancock said, we'll have to see what that is. We start the first part of January. Hopefully we'll be done in 140 days. And at that point, we'll have that year and a half that will be in the interim part. I think that at that point, it's good and it's bad. It's good from the standpoint that we have a chance to see what is happening and how it sort of works out. It's bad in that it'll be a while before we can really do anything. But I think, overall, that's going to be a great situation to be in. As we see, and as people, when they talk to me about wanting to change from meeting every other year to every year, it's like, it's nice to watch other states go out there and see what they do and what works, whatever the issue is, and then we have time to go in there and do it right. When we go to the conferences that we attend, everybody's always holding up Texas as the state to follow, or they're proud about what they just did and it was something that we did several years ago in Texas. So it'll be exciting, but guaranteed that it'll be kind of like the E-Ride from Disney. We will have to hold on to our seat. We will also, we're in a good position. We have a lot of clout as far as what we do. The rest of the nation, I think the country will look at what we do, and we tend to have a common sense approach. So it'll be exciting.
Okay, so let's get to the issue at hand. So, Commissioner Mattox, let's start with you, because let's get kind of the table stakes on the table. So, what action do you think TDI could take under existing law, existing regulation, to lessen the impact of a balance bill on a consumer or patient?
Well, thank you, and I apologize for my voice, so I'll do the best I can. I think the first caveat I always like to make is that when you're looking at health care, the majority of health care is either a government program or private insurance plans that are not regulated by TDI. So actually the Department of Insurance only regulates 19% of the market. So that said, it does not mean we can't have some impact. I think the biggest impacts we can try to help on is working with plans to get the information out that their policyholders need to really understand what's in that plan. Because a lot of the balance billing comes from a lack of understanding of where should they go, what is a freestanding emergency clinic, what costs could be incident to that. That's one thing. The second thing which we do and I want to continue to sort of preach this, is we have a consumer protection division. And I'll just digress a little bit to harp on that. We were recently ranked the best consumer protection division in insurance in the entire country with a score of 95, for some of our neighbors at a 20. And we can really help folks that do have issues with balance billing, trying to help them navigate that. But from a regulatory standpoint, I really can't dictate to the different companies what they can and cannot do. Again, some of that may need a federal regulation, some of it can be affected by state regulation. So the biggest impact I think we can have is trying to make sure insurance companies are forthright with their policyholders about what the coverage is and to help them navigate that.
So here we are. So I think everyone's painfully aware that the 85th legislative session is just around the corner. So Senator Hancock, so what do you see as the biggest challenge to these issues coming forward in the next legislative session?
Well, explaining it to most people, really. Most people, from a legislative standpoint, we only have to pass one thing, and that's the budget. And so letting them understand that this is an issue for their constituents back home, that is something that they have to deal with on a regular basis. And once they clue into that, then really what you do then is it's pretty easy to convince somebody to support legislation that they know is going to help their constituents. So informing them of the improvement that we've seen since mediation's come in place, letting them know about it. And so I think I'm overly optimistic, Jamie, but I think this is an issue that once we explain it to the elected officials and how their constituents are dealing with it now, and that we're trying to actually level the playing field and give them a better option when it comes to these surprise bills, I think we'll have pretty good success during session.
Okay, so Senator, you probably have heard every possible stakeholder argument between the physicians, the patients. So how do you split the baby so that you don't give one stakeholder an unfair advantage over the other in the area of balance billing?
Well, you have to start with recognizing that we have a horrible system. We have an incredibly complicated system that most people that are buying a policy, most people that are going to a physician, have no understanding of the complexity of the policy they're dealing with, the contractual obligations and relationships between the parties involved. And to sit there and explain it to them would take a college-type course to get them to understand the system we're in. But the reality is, that's the system we're in. The reason we came up with the mediation is because we did not want to play favorites with anyone else, but we recognize that the system we have benefits those that have a lobby. And the only people that have a lobby in Austin are the insurance companies and the physicians and the hospitals. My constituents don't hire people to come in and hammer us on legislation, so that's really our job. And so being a free market, I did not want to do like other states did and ban the process together, which is because there may be opportunities that someone chooses to go out of network, they choose to pay a premium, and I don't think we wanted to be in a position of doing that. The mediation process was a way of allowing some leverage to that consumer that they didn't previously have, and yet not involve them when they may be laying in a recovery room after a major surgery. We didn't want them having to deal with being in the midst of a mediation that really needed to take place between a provider and insurance company. And so that's kind of where we went. We tried to find a process that maintained some free market principles, and even though there are very few free market principles in healthcare these days, but we didn't want to eliminate those. But we gave the consumer, the patient there, the ability to actually do something instead of just get turned over to a collection agency.
So Stacey, talk about that a little bit. So should the patient be a part of that mediation, or do you think that mediation should just be between the payer and the provider?
So I'm working at the center with a coalition of consumer groups and patient groups like AARP, the American Cancer Society, MS, groups who have constituents and members who end up in emergency rooms or end up getting care that's out of network and they didn't know. And so what we've tried to do is identify what we think is the next incremental step we can make to help consumers here. And we have identified emergency scenarios as being the most important because that's when consumers have no ability to shop and see what's in network and control what care or who's giving you care. And we are advocating for what we'd call a complete consumer solution on that front, which is make sure at the point when the doctor sends the bill to the insurance company says, no, that value's not right. I'm going to pay this instead. And the doctor gets the reimbursement, says, no, that value's not right. They both right then know something's wrong with that bill. Instead of taking it and pushing it off into the consumer's shoulders for emergencies, we don't make consumers be the one who initiates mediation, but mediation would happen automatically. And I'll just say really quickly, I'm sure people know this, I think mediation is really a misnomer. What the legislature essentially did is say doctors and insurance companies, when they are in a dispute about these out-of-network prices, should just pick up the phone and talk. It's almost always just a phone call. And so I think the question is what kind of burden should we place on consumers' shoulders just to get these two parties to pick up the phone and talk, which is what the legislature is looking for.
Okay, so you brought up a very interesting topic because you kept saying emergency services, that's really what it should apply to. But one of those big stakeholder groups out there, the Texas Medical Association, has really said, let's apply it to everything. Let's apply it to in-network, out-of-network, elective services, freestanding emergency rooms. Let's apply it to everything. So really for the Senator Chairman and Stacey, you guys comment a little bit on that for me about should it apply to just emergencies or do all of these other services need to be incorporated in there as well?
Well, I think some of the physician groups got tired of being blamed for the balanced billing that they didn't create. And so I think that's what happened within the medical community with the TMA is they saw that their colleagues that had this in this specialty being exempt from what they were having to deal with, and then their patients were coming and getting angry with them or yelling at them or or telling them it was unfair, and yet they were exempt from this. The other thing we've seen, and one of the things we saw in our interim study, is we've seen a exponential growth in freestanding ERs. And we've seen that business model on some is very short-sighted because when you get balanced billed, you tend to not go back to that facility. Therefore, you don't have that repetitive business that you would like to have in the past. So I think bringing them all in, the reality is we recognize when the legislation was first passed that emergency room physicians do deal with some unique scenarios. And so we acknowledge that. For years, they were not the largest culprit in balance billing. That has changed. They now lead the way in that. And then the other thing we saw here recently within the last year is a new category that popped up, which of assistant physicians, because the physicians couldn't balance the bill. Now we saw the creation of assistant physicians, and now the assistant physicians are the second largest grouping that balance bills, that provides out-of-network additional billing. And so that we don't have to come back every time they create that we see a new classification pop up, I think it is necessary that we do an all-encompassing, so that you can come up with all the creative names you want to try to surprise bill or additional bill, but we're going to provide a framework that encompasses all of that when it addresses the same type of situation.
John Frullo?
Well, I think the other thing we need to look at, to kind of take a step back, first off, is the cost involved right now in these situations where we see the emergency situation creating a surprise billing or balance billing. First off, you have a person that oftentimes didn't expect to be in that situation, that may be taken by somebody or some type of service to the nearest facility to have that taken care of. And so there's things outside their normal course. I think the second thing is being able to have people understand what their policy is and what it covers. If you take a look at what most people pay for insurance premiums, I'll bet a good number of people, by the time you put their company portion together with the portion that they pay, they're actually paying probably somewhere between what their car payments are and what their house payment is. And so we're talking about big numbers, and that's what's happening. Chairman Hancock, as well as myself, have gotten calls from constituents that are complaining about a bill. Why did I get this bill? And what's going on? The mediation process, I think, is a good way. If you look at the number of cases that were mediated between 2008 and I think 2013, there were roughly about 200. 2014, there were right around 900. In 2015, there were about 1,100. Chairman Hancock worked on where we dropped the mediation cost from $1,000 down to $500. And it was kind of interesting because the average surprise bill went from $969 per bill after it was mediated down to $180. As Gomer Pyle would say, is gee Willis or golly gee, or I think it was golly gee, that's what he used to say. How did that happen? Well, as the chairman said, it's a complex system out there, but I think at the end of the day, a lot of it revolves around the big numbers that we see, and it's a very complex, hard to understand system, and one way is to get the people that actually have those policies to be able to understand and know what they're getting and what is covered. They, I think, a lot of times feel because I'm paying a lot of money and I've met my deductible, I'm taken care of, and that's not necessarily the case.
But I think the commissioner could address, what's unique about this, and I think we've seen this, is there are very low numbers on mediation. It's because the two entities that are to be dealing with this don't get along and don't want to talk to each other. What happens is they don't get along and they don't talk to each other, and then the patient suffers in the middle. And the minute that phone call is made to start this process, I think the commissioner will tell you very, very few go to mediation. My wife actually was sent a bill, and it was over the threshold. And I said, well, just let them know that you're gonna refer it to mediation. Immediately we got a notification that the bill's been paid in full. So the physician and the insurance company worked out the difference, and we were taken out. And we had gone through the process just like my constituents would have to, which was very painful and frustrating and took about 4 months. And then when we got the balanced bill, I thought, this is beautiful. I actually get to experience whether our legislation worked. And all it took was a phone call. And so I'd be interested to see what you've seen on your side from TDI.
Certainly, I think that really is instructive of what the mediation does. And I don't want to sound a bit too cynical about this, but a lot of what we're seeing is, for whatever reason, providers and plans just not coming to an agreement. And whether that's, and this is before the care is done, whether that's from the provider side saying the plans aren't offering enough money, or the plans saying the doctors simply don't want to contract with us. what this mediation does is actually create the ability, without going through a formal contracting process or even a process that's made public, for the plans and the providers to negotiate together. And it really is all about simply forcing them into a room to come up with a number. Because it's really in no one's interest at the end of the day, unless there's a good reason for it, to balance bill and patient. I think both the providers and the plans know that. So I think mediation gives an opportunity for that negotiation to go on that for whatever reason didn't go on before the care was given.
So I guess, Stacey, so the question is, do you think it should just apply to emergency situations? Does that satisfy the concerns of the consumer, or does it need to be everything, like the TMA description that I talked about?
So from the consumer point of view, we think the next incremental step we should take is definitely to focus on emergencies and do the complete solution. And by that I mean, don't make the consumer go through these unenumerated but complex steps that you have to request mediation. We've had 3,400 people who've been benefited from mediation in 7 years. And that's an order of magnitude or two smaller than the number of people we'd expect would be getting surprise bills, and fully insured plans are eligible for mediation, right? There are just too many barriers between a person who gets a surprise bill and getting to mediation. So we're saying take down those barriers. But if what the legislature does is the next incremental step, instead of taking down the barriers, is reduce what I call the loopholes. You can only mediate certain bills from certain doctors if you're in a certain kind of facility. If they go after the loopholes instead, then I definitely think it's important that we don't just look at emergencies, because our existing mediation system doesn't. Our existing mediation system recognizes that consumers can get surprise bills even outside of emergencies. For example, I suspect, because it's happened to me, that there's a lot of people in this room who've had planned procedures who could not get an answer on whether their anesthesiologist would be out of network in advance, even though you asked all the right questions, right? Given that that keeps happening, it's important that when we're cleaning up the loopholes, we're closing the loopholes, we're not just focused on emergencies. Consumers are focused on the emergencies for the piece that makes sure the consumer is not the one who has to initiate mediation, and that's where we're focused on emergencies.
Okay, so Stacey threw the question out there to our legislators. So just kind of reading that crystal ball, so what do you see? So what's the threshold look like, and does it apply, you think, to in and out of network, or all elective services, including emergencies as well? What's your crystal ball say?
Well, I think my crystal ball is broke. Maybe that may be a misnomer. I'm not sure it ever did work. It was wired backwards, I guess. I think it gets back to a complex problem, and as Stacey said, there's loopholes out there. The problem is Chairman Hancock said, if you plug 3 or 4 loopholes, well, then a new one is created, and so that tends not to work. And we're trying to fix a complicated system with easy fixes that works maybe for a short period of time at best, and then new situations open up. So I think what we have to look at is, again, how it works. I think one of the best ways is just educating the consumer to some extent, letting them know what it works. But as Stacey said, we've heard stories where they will have a particular doctor, and we'll pick on anesthesiologists, and look at what happened, where we had a person told me they went through their system, they found an anesthesiologist that was in their network, they went ahead, set up the surgery, had it done. Well, at the last minute, or for whatever reason, that physician was not available, and they substituted one, or one took the place that was not in the network, and then there was that surprise billing. So this was a person that did everything they thought they could, and unbeknownst to them, it was changed at the last minute. So it's working at the whole system. It's getting together, the House getting together with the Senate and working on the system. We saw that we had made some movement last time with the change in mediation. We'd looked at other parts of mediation, possibly changing that amount, and I think those are easy. They're not easy steps. Nothing is an easy step when it comes to changing insurance law, but they're at least items we can have that discussion on, we can talk about and look at, and work in that direction to make it easier, because this is really affecting people's lives. They're filing bankruptcy. They're it's changing their lifestyle over one incident, and so it's going to be difficult to work on.
Sorry.
But I think encompassing everyone, I think the fact that TMA recognizes this is a fair direction to go, and let's be clear, not all of their group believes that this is a fair direction to go, but they're, at this point seem to be supportive of that. That could change by the time session rolls around, and I imagine we'll have some of their groups splinter off and oppose us on this. But I think it is the appropriate next step. The other thing that we have to realize as elected officials is while the threshold is at $500, I have a large number of constituents that coming up with $500 is going to be a real challenge. And so while that threshold addresses it for a number of my constituents, it's a problem for a lot of them. I mean, a major problem for a lot of them. And so that threshold's still there. What you find in the legislative process is you want to pick your fights, and you want to pick fights you can win on doing that, and you don't want to pick too many fights so that you're too divided up that you create too many enemies. And so we're making a good step. I do think that which direction we go, the fact that most of my constituents don't have a clue on mediation process or that they can request it is a real problem. We need to, and I think the legislation that we'll propose will look to incentivize that and increase the awareness of that and the notification of that, because we need to communicate that better. We have a process that I think works. I think those of us up here would agree it works. The problem is that 99% of the people that get balanced billed aren't aware of it, and we've got to address that problem. That's one that we're going to need a lot of people's help on to make sure we address it in a way that we are communicating the benefits that Texas provides to those that are surprise billed.
Okay, Chairman, I want to switch gears just a little bit, and Lubbock always holds a fond place in my heart. It's a great place, Wild West, but it is being inundated with freestanding emergency rooms. I think 82nd and Milwaukee, 82nd and Slide Road, they're at 289 and Indiana. You've got 3 that I just going to mention right off the bat. So what are you hearing about freestanding emergency rooms, and what concerns do you have now, and what do you see as options coming forward in this next legislative session?
Well, first off, you said the Wild West. I think if you want to see the Wild West, go down to Austin about May and spend a little time either in the Senate or in the House chambers, which I know you have. It's what I've heard about freestanding ERs in Lubbock is one of 2 things. It's like you said, either come out and attend our grand opening, which there seems to be one a week, or it's people, friends of mine, and some one was actually a very well-known insurance agent that his wife actually went to a freestanding ER. I don't remember what it was, something like a sprained ankle or wrist, and left there with a $2,500 balance bill. And he was just going crazy over that. Somebody that you would think would know how that works. So it's part of it's education, I think. That's what I'm hearing is people go to there, and they always ask the question, will you take my insurance? Well, I own a printing company, and I'll be happy to take your insurance card. Now, it's not going to change your bill, but I'll be happy to take it. I say that facetiously, but they leave there, and then 2 weeks later, they're getting a bill anywhere from several $100s for something simple to several $1,000s. And as Chairman Hancock said, they go there once, and then they never go back. They won't go back. If you look at the construction where they typically are, they're not far from a freestanding hospital facility, I guess, if you will, one of the well-known hospitals. So they're typically in and I'm not knocking their model, but that seems to be where you see their location. It's either fairly close to a regular emergency room / hospital, or it's typically in a very prosperous part of town. And so I think the main thing is people need to know what it is they're getting into when they enter one of those facilities. Can they take care of you? Well, it depends on what it is. Typically, we see that if it's something really bad, they can stabilize you, and then you're going to go to that hospital. Oftentimes they can take care of you, but it's at what price? And you know, if you're willing to pay a price for that convenience, then I think that's you know, that's up to the people, and that's something. But they need to know that there is that price.
So Chairman Hancock, I will tell you, I've been at Blue Cross about 4 years, and this seemed to start with consumers having a challenge with a facility fee, and so that was something that wasn't really well known. And then there was imaging additives, and then just last week, you know, I had a group come and tell me that we're seeing observations occur in a freestanding emergency room. So patients are being held in the freestanding emergency room under observation for 3 and 4 and 5 hours and then discharged, which these bills are now in the $20,000 and $30,000 range. So are you hearing similar concerns in your district, and what do you see as a possible solution to that?
Yeah, I think we're hearing very similar concerns, and you don't even have to hear anything, you just have to look. I think in the last 18 months that there's 3, maybe 4 freestanding ERs that have popped up in and around, within maybe 3 miles of our neighborhood. And so you see this, you see the exponential growth in the state of Texas, and compare it to other states. It is significant. I mean, it is very significant. And it is where I think if balanced billing legislation is written appropriately and addressed appropriately, and then we make sure that the notification is more present and available to that patient, and they're become more aware of it. I do think that this legislation is one that could address this issue without impeding on the free market principles, but it also would keep protections in place for patients.
So Stacey, is education, is that all we need, or do you think there needs to be some more rules and regulations around freestanding emergency rooms?
So I think there definitely needs to be some more, another look at this. I think there shouldn't be fewer consumer protections if you get your emergency treatment in a freestanding ER than a hospital, right? So one good next step is wrapping them in existing mediation systems so that if you do get a surprise bill, you have a recourse as a consumer, right? I think that's a good first next step. Education is, of course, a key component to all of this, is making sure consumers know that there's a distinction between an urgent care center and a freestanding ER, and making that distinction easier. But I think we need to look at another thing that Chairman Frullo mentioned too, is this language that's pretty, you know, at the websites I've looked at, freestanding ER is pretty pervasive of, we accept all major insurance, which does not mean they're in network with your insurance. But consumers would think that, and I think we all know that consumers would think that the distinction there, that's not a very meaningful difference, and to make sure that consumers get very accurate and clear information about the network status of all providers, not just freestanding ERs, but including freestanding ERs.
So while we got you on the panel, and you're talking to a whole group of people who are interested in our insurance community, so what as an industry could we do better to educate our members on things like freestanding emergency rooms and making those choices?
Okay. You know, I've seen some information from insurance companies that I think is really helpful in educating the difference between, you know, where do you go in these certain situations. I think there's a lot of responsibility to be placed at everybody's feet for these problems, including consumers, and what consumers need to know and understand. But I think our biggest hurdle isn't identifying the education opportunities. The biggest hurdle is saying, in the situations where education disclosure isn't going to make a difference, when you have an emergency, when you're about to go into an operation and that's when a doctor is switched. In those situations, we actually need public policy solutions. And I think that's the biggest hurdle, because we have stakeholders who disagree on what the solution is. And so that's really where we're focusing. It doesn't diminish the need for education. I think that's just the easier piece.
So Commissioner Mattox, I think I know the answer to this question, but I'm going to ask it. So does TDI have an opinion or thoughts around a solution related to freestanding emergency rooms?
Well, I'm in the business of implementing policy, not making policy. But that said, I think that one of the things that's unique about health, which has always been a little problematic, and this goes back to my AG days too as well, it's one of the few things in our free market where you go in and ask for something and don't know what you're going to pay for it. And so just sort of speaking on the issue on the freestanding emergency room clinics, I don't have authority to tell them that because I don't regulate freestanding emergency room clinics. But one solution might be, not that we carry insurance, but this is how much your bill may be. And so then someone can say, whoa, then maybe if I go to that thing over there that's called non-emergency, it'll be cheaper. I don't know. But that would be one issue with respect to that emergency room. Because again, it's trying to get the consumer to really understand the cost. Because again, saying you're out of network, does that really translate to someone? What does that really mean if I'm out of network? Again, getting back to the whole concept of when we got PPOs to begin with, we wanted to give consumers the choice of going out of network and paying the additional costs if they wanted to. And there's nothing wrong with that model because then the consumer has the choice and knows they're going to pay more. The situations we're talking about here is where the consumer doesn't have a choice. And there's only so much education we can do with respect to that to help out that scenario. Now, one of the things that we do as best we can is looking at adequacy of networks, which again isn't the freestanding emergency rooms because I don't have authority over those. But you know, when someone is making a network, they need to come to us and establish that it's adequate. But what does adequate mean? So let's say you're in a rural area, and you come in and say, well, we're going to have this many primaries, and we're going to have some OBGYNs, we're going to have this specialty and that specialty, but we can't find anyone in our service area in this specialty. Well, we have two options. Say, all right, then you don't have a network. There's no coverage there. No one gets coverage at all. Or what we have is what's called an access plan. And an access plan then means that that company has to have a way to get someone who's not within network to provide that care. The problem then is you do get an imbalanced bill situation. So part of the issue is then trying to go out there and let the doctors know there's an issue here. Do you want to contract? But again, I'm without authority to either dictate to a doctor, a provider, or to a plan you must contract with someone. So what we do is the best we can with looking at that and trying to make sure it's as adequate as possible, but we're left with the binary choice of you have no network at all, so no one in that area gets coverage, or have an access plan, we go with an access plan. Which again, I think then makes it even more critical that if the legislature chooses to do so, to expand and make more fulsome the arbitration provisions, because then that's the way when you have those situations, the policyholder can really be left hold harmless, or at least not be in the middle of those situations.
Well, thank you. I think we have some time for some questions from the audience. If anyone can, I'm going to ask Chairman Frullo kind of a last question, and then we'll have some time to answer some questions from the audience. So, Chairman, I've decided to kind of throw this question to you. This is a challenging and vexing problem because we live in a state where we like free market, we like innovation. So the question is, how do you bring these stakeholders together on all of these issues, balance billing, freestanding emergency rooms? It doesn't stifle that innovation, but allows the stakeholders to be regulated, consumers protected. So kind of a long-winded question, but is there a solution, you think, that we can come up with in the next session?
Well, I think that there maybe is there a solution, a total solution? I don't know. I'd like to think so. I think that at least we could make it better. And again, we've seen some of that. Some of it is information, letting people understand or enabling people to understand. One of the things that I had a friend talk to me a while back that he was looking at for his company buying an insurance plan. And he said that, it's getting very difficult. The plans are costing more money. They're getting more complex. The networks are hard to understand. I look and my doctor's in the network today, but he's not in the book tomorrow. And then I find out the book's outdated and he really is, or she is, whatever. So there's a lot of things going on there that make it, much more difficult to figure out how it works. But as he was talking about, he said, I'm trying to figure out how it works and I can't do it, and I'm spending more and more money trying to make this work. So part of it is it's just gotten so complicated, and I think we need to look at how can we inform that consumer. Again, getting back to what I said earlier, a big portion of what both companies and individuals pay in their take-home money is being spent on insurance, and they're just assuming they're covered. As Chairman Hancock said, they probably didn't take that 3-hour course at the local university to figure out how insurance works. I think that part of it is getting information out. We've done some information getting back to the freestanding ERs where they have the big placards put up. People probably don't read them. I don't know. They must not be, because I'm still getting phone calls from people saying, "Can you believe this happened? How did this just happen? I've got my insurance. I've even actually met my deductible this year, and I just got this bill for $1,200. So I think it's a combination of things. It's not easy. It's getting information out and getting people to learn about the mediation. As Stacey talked about, different ways of getting the patient or the consumer involved in the mediation process, how that's initiated. It's not. I wish I could give your quote long-winded question an easy answer, but I don't think there is one.
I just think it's going to get worse before it gets better. I mean, when we look at what's happening in the industry, you have such consolidation. I mean, there are certain specialty groups in North Texas that there is no free market, that there's only one provider, and that they've combined. And so these associations of physician groups have just gotten larger and larger, and then the hospital groups have gotten larger and larger. And so the free market principles that you, I think, correctly address, that we in Texas really like, what we're seeing in the healthcare industry is those disappearing. That there is no competition. There's no competition for you. The number of competition for healthcare plans, really in certain areas, it's limited. And so we're seeing this work backwards than I think most of us on the panel would like to see it happen, which is that there is more and more competition in order to provide consumers more and more choices, in order to provide plans more and more choices. And on top of it becoming less and less free market, it's becoming more and more complex. And even though we have technology that we're using everywhere else, and you're using it internally within your organization, you're not using it with your consumers. And so I think both from a provider standpoint, I think it's time that we use technology to update, that there is absolutely no reason that any of your policy holders cannot know instantaneously who's in network and not in network, because internally, when you do your billing, when you do your contract negotiation, I guarantee you your internal records know exactly who's in network and who's not in network, which tells me it's absolutely a possibility for your consumers, those buying your plans, to know the same time that those are inside your company, to know that those that are outside buying your policy should be able to know who's in plan and who's not. The flip side, physicians don't even know, because they're working for associations now, they don't even know what they're charging. They don't even know whose plans they're in, so they don't know anything, which makes it impossible for the patient to show up and ask the physician, what's this going to cost? Am I covered? Are you in my network? They just look and say, oh, I don't know, I work for an association, and they do all that contraction. I don't know anything about it. And so the healthcare industry as a whole is going completely backwards when it comes to free market principles, which is causing all kinds of problems. And then we don't want to use technology to communicate better with our patients than we are now, or our insurance policy holders, which is absolutely ludicrous, because we will use it internally. We just don't want to share that information with one another. And then, as you alluded to again, physicians hate you and they don't want to talk to you, and you hate them and you don't want to talk to them, and therefore the ones that gets hosed in the middle is the patient, and it happens time and time and time and time again.
Great response.
That's just kind of what I'm thinking.
So anyone have a question for our group?
I think I need a prescription for an antidepressant after listening to all these conversations. Given the people on the stage, and given the fact that we pretty much have to buy health insurance, who's out there to protect us? Who's going to take the lead on protecting consumers from the games that freestanding ERs play and the balanced billing, I'm not hearing where the solutions are. I'm hearing that, well, it's a complex problem, it's, this, that, and the other thing, but I'm not feeling any comfort that we're going to leave here knowing where this is going to go in the next year or two.
Well, I think it's multifactorial. I think that's what we've heard, is that it's a very complex problem, so there's not going to be a simple solution. But I do think what we heard today is that, and I'm kind of restating the panel, is that mediation works, mediation needs to be expanded, and consumers need to be educated for their opportunities. And boy, do we need to be careful about things that destroy free market if we're going to rely on free market principles to help solve the problem, like consolidation. Is that fair? So while we're waiting for another question, while we're waiting, let me ask Commissioner Mattox. So one of the things we heard real quick today here was that network adequacy is a challenge, and basically, particularly looking at health plans and making sure that they have an adequate network. Do you feel like you have the adequate resources to assess network adequacy?
Well, I think that we're actually reanalyzing and trying to do that. I mean, we have a large group, part of which is looking at solvency, part of which is looking at the adequacy of network on the front end. We have a different group that looks at complaints on that, and another group that looks on it on the back end to see if it's coming in there. And again, getting back to what I said before, we'll have a situation where you may be in a rural area and they can't get one specialty. So we work with the plan and say, what can you do, what can't you do? And if they can't bring any doctors in, then we have to have an access plan. So, I don't know whether there's a way to incentivize either the doctors or the plans. I know folks would wish that I would go in there and somehow magically dictate, go contract with this plan, but that's not our free market. And again, part of this could be, again, more openness, and again, like I said, as opposed to just saying you're out of network, tell them how much it's going to cost. Now, there's all kinds of issues with that, I understand. We don't know what it's going to cost, depends on what you're getting and what services are. But if you don't empower consumers at the front end, you're not going to start balanced billing, because they're just going to get the treatment and hope it's covered. And so I think that's what we really have to look at, because you can't, insist that people contract with each other. So again, I would always say as a regulator, give me more resources, but in this situation we have right now, I'm not going down that road. We are looking at some reorganization to see if we can refocus some resources in that regards. But I do think that we do have appropriate folks there. They're just not in necessarily the areas that certain people looked at when they were talked about. So thank you.
Okay, I have a question about something you talked about at the very beginning. The idea that it might not, whatever happens in Washington may not happen until after we're down the road, so it may be in 2019 before the legislature can react to repeal and potentially replace. So my question, I guess, is almost more for the commissioner. Do you think there is an insurance code provision that says if there's a federal law, you can take action to protect the citizens of the state in between sessions. So do you think you have maybe what you need by that statute to address what happens if it's repealed? Because the risk pool did get repealed, so we don't have an insurer of last resort in Texas, and they're in big shape.
Well, that was the one point I was going to make. It depends on what you mean by repeal, because we just heard the president-elect say, but I'm going to keep the provision on pre-existing conditions, the ban on that. So, what all the states did, not just Texas, but when the Affordable Care Act was passed, they all got rid of their high-risk pools. And so Texas had a high-risk pool that allowed people who could not otherwise get insurance to go join that high-risk pool, and people could argue about how good it was or wasn't good. But all the states have gotten rid of that. I don't think that's going to be lost on Congress. But if you're saying, could I, by administrative fiat, create a high-risk pool? Not in any world I live in.
Patty is a good point. So what we may need to look at, and we'll work with the commissioner on this, is establishing for that criteria, because we don't want people to fall into the crack, and if then legislative fix to that. If something were to happen before we come back, then he has that, but then sunset it once session started. So we could give him that authority in statute, and then sunset it, that it only lasts, one session, so that when we come back, then we can address it properly.
And just the AG and me will jump out right now. We have to be careful on that on the separation of powers issues. So, I mean, we'd have to the legislature would have to be fairly specific in what the authority was granting me. They couldn't simply say, if there's a problem because the ACA gets repealed, go fix it. That wouldn't constitutionally work. Yes, guidelines, yes, sir.
So we probably have time for maybe one more question.
I was going to ask a question. So a second ago, Stacey mentioned that many of the freestanding ERs, or some of them, are actually advertising Blue Cross Blue Shield is, we take Blue Cross Blue Shield, we take Aetna, we take Humana, and they may not actually be in network for a single health insurance company. And we've talked about transparency for consumers, so even when the consumer is looking it up, educating themselves, it's confusing for them with this information. But TDI only regulates insurance companies. So there's only one agency looking at all of this, and the only people they have any power over is health plans. So are there solutions to deal with deceptive advertising or misleading advertising around network status on prices so that consumers aren't confused in the market in the first place?
Thanks, Kelly. I think part of it is looking at what it actually is. And Jamie, you've given us brochures in the past that say this is what the bill is. If you're at a freestanding ER and at let's say I hate to use the term normal hospital, but a normal hospital, and it goes down through the various steps. And that particular brochure, if I remember correctly, did actually, using whatever form of insurance that scenario provided, reduce that bill. So, in actuality, did having that insurance reduce that bill from what it would have been? Yes. And so it's kind of hard to say, well that was, I'm not sure if this is what you're looking at, but if that was deceptive or not, because at the end of the day, it did reduce it from what you would pay at the full retail pricing. I think getting back to what we've kind of harped on here a little bit is just educating that person, because had they gone again to that freestanding ER, and let's say that bill was $1,300, by the time they got their discount and everything, they still paid, let's say, $800. Whereas had they gone to the hospital, their bill would have been $110. And so at the end of the day, they were probably expecting a $110 bill, and when they got that $800 bill, it was a surprise again. And so I think that there's things that need to be done, but as we start narrowing it down, people will find a way to get out of it or get around it. So I think what we need to do is, again, there's nothing that's more powerful than an educated consumer, and I think that's where we need to go.
Well, thank you, and I'd like, if I could.
Let me say on that, I don't think you need us that much. I mean, right? They're using Blue Cross's name. They're using their sign. You've got a contract with them. You don't want them taking advantage of your name, your sign, your identity. You have a contract with them. I mean, if they're saying that inappropriately, then my recommendation is look within your own contract with them. Now, if they're using that name and sign and they have no contract, my guess is that there's already statutes in place that can address with somebody advertising that they take Blue Cross Blue Shield and they don't. But I think before coming to us is a way, look at it, seeing what you can do within your own industry to cramp down on that and apply some pressure on those that may have a basic contract that are acting like they have the full-scale contract. I know you would, I would think you would have our support on that.
Thank you, and let's give this panel a big round of applause. Thank you for being here.